equity. From there, we'll dive into the Affordable Care Act, or Obamacare, and the opportunities, the challenges, the implications it's created to advancing the health equity agenda. We'll focus on two aspects of the ACA. One is the health insurance provisions, which really has gotten most of the spotlight, but we'll also delve into health care systems related provisions as well. And then we'll get into a closing discussion. So a little bit about THI. We've been around for over 50 years. Our mission is to improve the health of Texans and their communities, and so that means communities at large, nationally as well. We are a nonpartisan, nonprofit public health research and policy institute. We do like to think of ourselves as a think tank. We do strive to think out of the box to really help advance research, advance education, and advance community-based solutions. And so a lot of our work focuses on I would say a breadth of health policy and public health topics, from access to care, health disparities and equity, which I'll be talking a little bit more about today, chronic disease in particular. We have programs on obesity, and we do an annual Southern Obesity Summit. Some of you may be interested in that. Mental health, community capacity building as well, so working with communities to help identify their healthcare needs, but then working collaboratively with them to help identify and craft solutions. Our health equity program, so we have a department and a team. We're led by Dr. Dennis Androulis, who's a senior research scientist at THI, who's really been the thought leader in working to expand our health equity portfolio. And so we've had our hand in several different aspects of the topic of disparities and health equity. One of the prominent ones, and what I'm talking about today, is really monitoring health reform from that health equity lens. And so we've been monitoring the health reform landscape since 2007, and I want to say now almost a decade. It started with comparing, contrasting, and understanding the Republican and Democratic platforms back when Obama and McCain were running for their presidency, and it morphed into understanding what the bills and the opportunities were, then the enactment in 2010, and now we've really been monitoring progress, implementation, and population implications. And so our areas of focus really, there's a lot of folks, a lot of body of work out there on healthcare reform, on the Affordable Care Act. Our specific niche has been monitoring the law from that health equity lens. And so we've been particularly interested in health insurance. What has the opportunities meant for communities of color, for racially and ethnically diverse populations, low-income populations? The healthcare safety net. So as newly insured come into the system, what does that mean for system capacity? Workforce support and diversity, what does that mean for the health professionals, for health professions capacity within our system, and ability to meet that growing demand that we're going to see from the newly insured. We're also focused on the law's provisions around data, research, and quality. And then finally, public health and prevention. So key and important is that while health insurance has really been in the spotlight, this law was more than just a law about health insurance. It really offers a very holistic opportunity, comprehensive opportunity to begin to revamp several different components of our healthcare system. So before I proceed any further, a definition of health equity. There are many different forms and definitions out there. Paula Braveman in particular has some extensive work. The definition that's really widely used, put out by CDC, HHS, OMH, and the National Partnership for Action to End Health Disparities, says that health equity is the assurance of conditions for optimal health for all people. So it's about creating an opportunity for everyone to achieve optimal health. Achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustices, so understanding that there may be a history behind why we're seeing differences in health outcomes and health opportunity for populations that may be defined by history, and providing resources according to need. We are not going to all need the same kinds of resources to get us to that optimal level of health. And that's really what health equity is about. Health disparities or health differences in health outcomes will be eliminated when health equity is achieved. So this is one of my favorite visuals to help define and differentiate health equity from equality. And I'm sure many of you have come across this in some form or another, but this is my favorite. And this really shows it's not about giving everyone the same resources. So if we give everyone the same size crate, and everyone, we're all different sizes, different heights, so if everyone gets that same size crate, we're not going to be able to reach that apple or optimal level of health. Reaching the optimal means tailoring and giving every individual the resources according to their need, understanding their underlying historical context, the communities within which they live, and then distributing them those crates according to need. And that's what will assure that we all can reach that apple or that optimal level of health. What contributes to health equity? So this is one of those questions that can take days for us to really wrap our hands around. We actually have a new grant. Actually, we're about 6 to 7 months into a grant from the Robert Wood Johnson Foundation in collaboration with organizations around the country to develop a national health equity index that will provide an opportunity for us to measure how far are we coming within states, within communities, to achieving health equity, and what distance do we have left to go. And so interestingly, this was a question on the table. Well, if we're going to develop indicators and measure health equity, how are we going to define health equity? So we spent, I would say, about 2 days as a group, a collaborative. We spent another day with a national advisory committee of major thought leaders around this to try to wrap our hands around what contributes to health equity. So it is a very complex question. And as you can see, there are a whole host of underlying social determinant factors that create our opportunities from health. They go as far as upstream to our political context, the social policies, housing policies, public policies, the healthcare reform law. I mean, all kinds of policies that really shape a community's opportunity that then may impact socioeconomic position and opportunities for education, employment, that then in many ways contribute to our ability to lead healthy and make healthy behavior choices and decisions, and then ultimately contribute to health. And then, of course, there are all sorts of interrelationships and interactions between these different factors. So a whole host of social, economic, environmental, racial, ethnic factors that contribute to our opportunity to live our lives to the full health potential. And for the sake of time, this was really, to me, the visual that really captured a lot of this. So a lot of you may have heard with the Ferguson case in Missouri, a lot of you may have heard about the Del Mar divide that gained a lot of attention. So what we see here is a neighborhood in St. Louis, Missouri, where the street right here in black, this is Del Mar Boulevard. The north of that street is an environment, is a community that is predominantly African American predominantly low income, 99% African American, 5% have a bachelor's degree. Just to the south of that street, you literally have to walk steps. South of that street, a starkly different community. This is a community with greater income, greater home values, 67% of bachelor's degree, and it's a predominantly white Caucasian community. And what the Ferguson case brought to light was the fact that place may be an even more important predictor of your health than your genetics and your genetic code. And that is because these very environmental factors, a community where you have knocked over street signs, collapsing houses, sidewalks that may be unwalkable. So you have unsafe parks is how this neighborhood was characterized. To the south of it, the completely different environment. And so the opportunities to lead and make those healthy decisions really differ. Whether as a clinician you're providing someone guidance on improving their physical activity, improving your diet, eating and consuming more fruits and vegetables. Well, if those opportunities aren't there, if there are no sidewalks and safe parks, how do we ensure that then those individuals in those communities can make those healthy decisions and lead those healthy lives? And so, to bring home the point, this community up north has among the highest rates of death due to heart disease, cancer, very poor health outcomes as compared to the community immediately south of Del Mar Boulevard. So health disparities, health equity, why do they matter? There are many, many reasons, and I'm going to focus on three, I would say, primary reasons. One is we are growing in racial ethnic diversity. Our community is evolving racially and ethnically. By 2050, the nation will have a majority of non-white populations, so about 46% white Caucasians, 30% Hispanics, 12% Black, and then we'll have a 12% Asians and a mix of others. Now what's interesting is Texas is exactly right now where the nation will be. We're at the forefront of this demographic, this racial ethnic transformation. We're almost like, if you've heard Dr. Stephen Kleinberg of Kinder Institute speak, we're like a petri dish. We're testing ground to understand many of these important health, socioeconomic issues. Now by 2050, importantly, we are also going to transform into an even more racially and ethnically diverse community where 34%, so just about 1/3 of the population by 2050 will be white Caucasian. Majority, half will be Hispanic, and then we've got the other racial ethnic groups. Again, this is what I borrowed from Dr. Kleinberg, so if you've seen him, if you've heard him speak about the transformation that Harris County has been through, I think these maps are really, really telling. Where, there we go. So this is 1980. The red shows, red represents white Caucasian populations. The gray color are African Americans. Hispanics are orange. And then a multicultural, where there's no majority racial ethnic population, those are considered multicultural communities, and those are this yellow color. So you see this transformation happening in 1980, 1990, 2000, and 2010, where Harris County is a truly multicultural melting pot. And so the importance here is that if we're growing, if we're going to be this multicultural society, then imperative to all of our health is making sure that everyone's on board to having good health. There's the human aspect of it as well. So there's the diversity aspect, where our country is going in terms of its population. But there's also just the moral moral responsibility and the human toll that disparities cost. There are persistent and pervasive racial ethnic differences in health coverage, in access, in quality to care, and outcomes that really were spotlighted in the Unequal Treatment Institute of Medicine's report that came out many, many years ago, from which much of the disparities field really was born. So I'm going to go through really quickly some of these slides, since I'm sure many of you are familiar with racial ethnic health disparities in one aspect or another. But disparities exist in health insurance coverage, and of course the Affordable Care Act was set upon reversing some of those trends. But as we can see, Hispanics nationally, these are national data, have the highest uninsured rate, followed by blacks, African Americans, and then we've got whites. And we'll go into these data in detail. The point here is there are differences in health insurance coverage and access to coverage. There are disparities in healthcare access. So even if you have a health insurance card, there may be other barriers: transportation, not being able to find a provider, and appointment wait time. So there are a whole host of access to care barriers. And the Agency for Healthcare Research and Quality annually puts out a report that tells us how are we doing in terms of the magnitude of these differences in healthcare access and quality by race, ethnicity, and how have those differences persisted over time, and what do we do what more do we have to do to close those gaps? And so what these data show are that blacks, Hispanics, Asians, American Indian, Alaska Natives, all non-white groups have far worse access to care opportunities than their white counterparts. It's certainly far more pronounced for African Americans and Hispanic populations than for others, but those disparities still do exist. Disparities in quality of care. So AHRQ also monitors quality of care disparities. And so again, same theme is that non-whites receive worse care than their white counterparts. And there are a whole host of reasons for that, whether it be patient-provider communication, whether it be education, whether it be, there are a set of measures that really contribute to this factor. And again, we'll get a little bit more into that discussion. So from quality, health status then, health outcomes as well, we see considerable differences by race, ethnicity. So I've pulled data from CDC. This is US, and we've got Texas here. And these are from the behavioral risk factor surveillance system, where individuals are asked to self-report their health. Are they in very good health, fair, or poor health? And so these are percentages who are self-reporting that we have fair or poor health status. And so again, importantly, we see Hispanics and African Americans, both in this state, and American Indian Alaska Natives reporting poor health status, both in this state and nationally. There are disparities in life expectancy. And so in particular, African Americans live about an average of 5 years less than their white counterparts. And so there are major disparities in this arena as well, nationally and within Texas. Infant mortality, again, much higher rates among black African American populations in the U.S. and in Texas. Heart and cancer deaths per 100,000. And so these are just meant to serve as examples. Again, we see much higher rates for African Americans both nationally and within the state of Texas. Hispanics, interestingly, and other racial ethnic groups have much lower rates in both arenas. Now, this doesn't get into the subpopulation issue. So if we just aggregate Asians, we might find different patterns, but we'll leave that for another day. So the third is, so we talked about we're changing demographically. We are becoming increasingly diverse, so it's important to be sure that everyone's on that bandwagon to health. We talked about the human toll, that disparities exist in health status, health outcomes. They lead to shorter lives, more preventable deaths. At the same time as well, there is an economic burden of inequities. And in 2009, Tom Leviste and a group of researchers put out a study that really measured if we didn't have these differences in health outcomes by race, ethnicity, if we prevented that, what would it save us? So they measured both direct and indirect medical costs associated with health inequities. Direct costs are if someone's coming in for very preventable conditions through the ER, for example, something that could have been taken care of in the primary care setting, then you're certainly spending more on that. Preventable conditions, the money you directly spend to care for preventable conditions. The indirect cost of inequities is the loss of productivity, the cost that it has on our economy. So lost productivity, lost wages. So they looked at both of these aspects as well as a third, which was preventable deaths. How many deaths would we prevent if we didn't have these disparities? So what they found was that 30% of direct medical expenditures for African Americans, Asian Americans, and Hispanics are considered excess costs to health inequities. In other words, potentially preventable costs. So eliminating these health inequities for minorities could reduce direct medical expenditures by $2.29 billion. And combined costs, so if you're now considering costs of inequity that factors in the indirect and the direct, along with preventing premature death, we're talking about potential savings of $1.24 trillion. That's the size of India's economy when this study was taking place in 2009. That's how much inefficiencies in our healthcare system, and in particular inequities, cost us, and a major business case why we'd want to reverse that trend. So the Affordable Care Act came into play, and from our perspective, really a key and central focus of that law was to advance health equity. Health equity and a focus on diverse communities, the opportunity to really level out the playing field for all populations was at the heart of this legislation. And there are 5 areas, as I mentioned, that we've really been monitoring very closely from a health equity perspective in terms of the implications and opportunities for diverse populations. There are the health insurance provisions. So the individual mandate a requirement for everyone to have insurance, the health insurance marketplaces, Medicaid, and a set of other provisions. On the healthcare access and delivery side, we've been looking into provisions around enhancing provider capacity, so support that went into health centers, delivery system reform. So what are new and innovative ways that the law has supported delivery system improvements? And a host of other programs. We've also been interested in workforce provisions. So what opportunities has the Affordable Care Act created to increase the supply of providers? And importantly, also tied to that, increase workforce diversity to be sure that the providers and those serving communities are in fact at least reflective somewhat of the communities they're beginning to serve. And also redistribution of professionals, and this was something that really came out of this law. Was it's not that we have a shortage everywhere of providers, it's that in many cases there may be a mismatch and a need for redistributing providers in underserved communities to meet needs. Data quality, so creating an evidence base, are other set of provisions within the law, as well as public health and prevention, including the Public Health and Prevention Fund, that really is funding a lot of the community-based work that's happening, community health center support, workforce provisions, as well as many others that we'll get into. So I'm going to focus a little bit of my time. I was asked to focus on the implications and impact of the ACA's health insurance provisions. So we're going to talk a little bit about that and see what the landscape looks like post-ACA, post-reform. I'm going to focus really, so there are many provisions focused on expanding health insurance coverage in the law. There was, of course, the individual mandate, so everyone is required to have health insurance, with some exceptions and some exemptions. The state health insurance marketplaces that all states were required to set up either on their own, so we've got the state-based marketplaces, in partnership with the federal government, or entirely run by the federal government, which is what we have, as you know, in Texas, and so we work through healthcare.gov. And then there was the state Medicaid expansion that was by law requiring all states to expand Medicaid. Of course, this was contested. The Supreme Court came back and said that the feds cannot coerce states to expand Medicaid, and so it became an option. And of course, in our state, we are not expanding Medicaid. And then a whole host of other provisions, dependent coverage and non-discrimination, that I'm happy to talk about if there's interest after the presentation. But I'm going to focus on marketplaces and Medicaid expansion, because those are the two largest and most impactful provisions from the law. So post-ACA, what we have here is a map of uninsured rates in 2013. This was in the period just before health insurance was sold on the marketplace and Medicaid expansion took place. And then post-ACA 2015. And so we do see, so from the darker colors mean higher uninsured rates, lighter colors lower uninsured. So we do see this dramatic transformation in these last 2 years, where nationally 20 million uninsured have gained health insurance coverage. And these are the latest data that came out earlier in March. The uninsured rate for non-elderly adults dropped by 43%, so from 20% at a national average to about 10%, to 11% nationally. In Texas, we also benefited and gained from the coverage expansion, in particular marketplace coverage. The uninsured rate dropped by 1/3 among non-elderly adults, from 25 to 17%. But what's important to recognize is that Texas, we're one of those fewer states that still has those very dark colors. We still have a very high uninsured rate. In fact, we have the highest uninsured rate in this country, and we have the largest number of uninsured in this country. So what did the uninsured rates look like by race, ethnicity, since that's really what our focus has been? Uninsured rates have declined across the board. So all racial ethnic populations have benefited from the law. A lot more people have an insurance card than they did before. But the important point here is that disparities do continue to persist. In particular, we're seeing, so we've got two charts here. We've got U.S. and Texas, and we've got the uninsured rates for 2012 and what was projected to be the uninsured rate this year in 2016 based on enrollments to date. And so again, what we're finding is that everyone's rate dropped. So everyone dropped nationally and in Texas. But we still see rates are much higher for Hispanic Latino populations, for example. And they're still higher when you can compare populations non-whites to white populations to their white counterparts. So we are still seeing those persisting disparities. And so I think about that, the tree and the crates again, and something likely needs to be done to help some of those other populations reach their full potential of attaining health coverage. So in Texas, we have 5 million uninsured, highest number, highest percent in the country. Lots coming out on this. In terms of marketplace coverage, so just a few words on the health insurance marketplace. So the health insurance marketplace, healthcare.gov, was set up to help individuals shop for, compare, and buy coverage in the individual market. So anyone without employer-sponsored coverage, anyone who is self-employed, others not able to get coverage from other sources, not eligible for public, for Medicaid, Medicare. And so the ACA provided 2 forms of financial assistance to individuals with incomes at the 100 to 400% of the federal poverty level on a sliding scale basis. That assistance would lower the monthly premiums in the form of tax credits, and there was also financial assistance to help lower out-of-pocket payments, so to lower deductibles or to lower cost-sharing co-payments and so forth. And so in Texas, over 1.3 million Texans have enrolled through healthcare.gov. And we see that a very racially and ethnically diverse population has benefited, has enrolled in marketplace coverage in the state of Texas. About 38% white, 37% Hispanic Latino. We've got 15% Asians and 9% African American, and then we've got 1% of other racial ethnic groups. Now, for folks who might be even interested in stats at, say, the county level, Families USA has put out some interesting data as well. So, for example, what they show is 4 of Texas's counties are the top enrollers of Hispanic Latino residents, and they've looked at who's among the top enrollers when we get down to the county level enrolling African Americans. Again, 2 of Texas's counties are there, and so they have some other data if you're interested in that. So why are so many still uninsured? We said the number was 5 million in Texas. Of course, most of you know we didn't expand Medicaid. But then there's a group that's still eligible for healthcare.gov but is not enrolled. So that's an important factor as well. There's the family glitch, where low-income spouses of individuals who are employed by companies. So the interesting thing is the Affordable Care Act required that all employers provide affordable coverage to their employees. That doesn't include family members. That just includes employees. So that's created a family glitch where the spouse then, oftentimes among low-income families, the child may be covered by Medicaid or CHIP, but it's that spouse who remains uninsured because they can't get coverage from the employer. That coverage is unaffordable. At the same time, they're not eligible for Medicaid, and so we have this gap for the spouse that's created. There's the undocumented immigrant factor as well. And then there will always be some who are ineligible or exempt. We're going to have a group of uninsured regardless. So Medicaid is one I want to focus a few moments on. And I'm sure you've heard about the Medicaid coverage gap, which is that region. So Medicaid in the expansion states that have decided to expand, Medicaid is covering individuals whose incomes are at 138% of the federal poverty level. The marketplace is covering folks from 100% of the federal poverty level to 400%. In the state of Texas, we have the lowest eligibility of all states. So we're not expanding Medicaid, and we have the lowest eligibility. That means childless adults are not covered. That means parents whose income is at 18% of the federal poverty level qualify. That's about $5,000. My math could be a little off, but it's a ridiculously small number for eligibility. So what that means is here in the state of Texas, we don't have Medicaid. We've got folks who are eligible starting this 100% federal poverty level. We virtually have this entire pool of individuals who fall in this coverage gap and are not covered. Who are these individuals? We talk about disparities. A majority are non-white. 55% are female. 69% are from working families. 66% are childless adults. 34% are parents. So I want to just to really highlight where we are and how bad we're doing in Texas. Texas has the largest number of non-white uninsured in the coverage gap. There are 3 million Americans in the ACA coverage gap, of which 57% are non-white. We have a very large proportion, really 750,000 people of color in this coverage gap. And so we only trail after Georgia in terms of the proportion who are non-white in this coverage gap. Then there's that group that I talked about who are eligible for coverage through healthcare.gov, but they're not enrolled. So as you remember, there were 1.3 million who were enrolled of 3 million who are eligible for coverage through healthcare.gov in this state. Nearly 60% of them have yet to be enrolled. So we've reached about 40% of these people, but we still have a ways to go. And as we've been keeping up with the news, in terms of numbers, we're just a large state. And we are enrolling in terms of numbers a lot of people, more than most other states, but we still have a ways to go to really get everyone covered. Now, our work has focused a lot on understanding what are barriers to coverage. I mean, there's this opportunity here. The ACA is out there. Everyone has this, I won't say everyone, most individuals have this opportunity to get coverage. Why aren't they enrolling? And so we've started to do some community-based work and surveying to begin to understand underlying barriers. So as we said, a large proportion are non-white populations. And so we're talking about, in many cases, the hardest to reach are those with limited English proficiency. They're among those that are very difficult to reach. But then there are those, if you put language aside, we're talking about non-immigrants, we're talking about, there are other factors playing out, such as health literacy and health insurance literacy. Many just don't understand what health insurance is, how it works. Many don't understand that coverage through the marketplace is different from Medicaid. There is a financial stake now. You're paying monthly premiums that you're responsible for. There's a deductible you have to meet. So it's those in and out, and that in many cases is a key reason why some may know about coverage but are still resistant to enroll. Then there's trust, especially related to immigration status. And fear of being identified, or fear of having a family member be identified if you go through the enrollment process. Then there's familiarity, both for immigrants and non-immigrants, but just general familiarity with the healthcare system and how things work once you get coverage. And then tied to that, for folks like ourselves, for many who are involved in community-based research, it's really not having adequate disaggregated data that limits our ability to identify those populations most in need and then to target some of those outreach and enrollment efforts. So if you're interested in this topic, we do have several reports we've put out. These are the two most recent ones, Strategies for Reaching and Enrolling Diverse Populations. We put one out last summer that really gets into outreach and enrollment across the different kinds of state marketplaces, gets into the barriers and how to overcome those barriers in working with diverse populations. And there's another we put out a year ago as well, each really following closely the enrollment periods. Now, really important to recognize is that health insurance is not healthcare access. Having a health insurance card does not guarantee that you're going to be seen by a provider or that you're able to access care. While necessary, it's not sufficient. So factors contributing to health care access, much like that World Health Organization framework that I put out on social determinants that contribute to health equity, there are a whole host of community, health system, and individual level factors that affect a person's ability to be able to access care. Within communities, it's your healthcare infrastructure. Do you have providers nearby? Transportation. It's economic security. Are there enough jobs to assure a wage to assure that a person can afford their coverage? At the systems level, what's really rising to the top is this issue of network adequacy, where now people are saying, well, I have an insurance card, but I can't see the provider I used to see. They're no longer in my network. Or that the networks are so narrow that a provider is extremely far, and they're not able to access it, compounded by the transportation barriers. So a whole host of their problems. Systems are inundated. We have so many more newly insured coming in. Next available appointments are becoming extremely difficult to identify. Compounding that, there then may be those individual level barriers that we talked about, such as health literacy, language, proficiency, and trust, and so forth. And so again, this is a report, I probably shouldn't have put this up, but we're getting ready to release this report very soon, and this gets into, it's a pilot study we did in South Sacramento in California to understand why are individuals who are newly insured, who have an insurance card, still facing barriers to accessing care. And so we found a whole set of interesting patterns. Limited health insurance literacy as being among the top themes, so a need for really educating these individuals. Still high ER utilization rates among the newly insured, and comparable to those who are uninsured. So again, really pointing to perhaps some underlying community factors that may be playing a role here, or a need for education, cost affordability, narrow network providers, a lot of the themes we've discussed. There's some interesting now data coming out about post-ACA, what does healthcare utilization look like? And so this really, there are a set of charts that I've got here that really hit home the point that disparities, that we're doing better. Healthcare access is getting better, but disparities persist. Where, for example, we continue to see African Americans and Latinos still having a higher probability of foregoing care that they need even after the fact of the ACA. Similarly, ER usage, we're seeing some change, but we still see these persisting disparities, and in particular higher rates among African Americans as compared to other groups. Probability of having any kind of a physician visit after the fact of health reform. And so rates are highest among whites, as you would expect, and African Americans, but much lower for Latino populations. So why aren't they going in to seek care, we may ask. So of course now we've got these newly insured populations. We are expecting and are seeing a strain in our healthcare system. The Commonwealth Fund in particular is monitoring this and monitoring some data. In addition, it was found that in Harris County, the predicted post-ACA demand for primary care will increase by 30%, leading to a 25% drop in demand met by safety net providers. So we are talking about a really, really inundated system here, and the need then for more system innovations. And this is something THI has really been getting into, especially as we work with communities to identify their changing dynamics and needs. So the ACA wasn't just about health insurance. It wasn't just about access, but it was also about transforming the healthcare system and supply. So health center expansion, as I mentioned, a lot of money went into health centers to expand their capacity. They are a major source of care for uninsured, especially in Medicaid non-expansion states like Texas. There are delivery system transformation efforts that are really being supported by the ACA that work to meet the triple aim. That is, how do we achieve better health outcomes whilst providing good quality care and reducing our costs and our inefficiencies in the system. And so patient-centered medical homes, team-based care, I know many of you may be experiencing some transformation as you practice in these systems, and so team-based care is one that's really rising to the top. And the theme in these delivery system transformations is, how do we now begin to reward value, reward health, instead of rewarding volume? So let's pay not by how many services you provide, but let's pay for those positive health outcomes that you're going to achieve for a group of patients. And building a healthcare workforce as well was a major component in the law. Two more really just important points. ACA really recognized, and this was a real winner for many advocacy groups, that communities are at the heart of healthcare transformation. We can't transform our healthcare system without understanding and really seeing communities as assets. And so there was support for community health needs assessments, these transformation grants focused on obesity, physical activity, nutrition, this movement to really help hospitals, health systems partner with communities. And then the final is really, how do we begin to measure our progress to advancing health equity? And so a lot of provisions in the law as well. And I could go on talking about this. So in closing, health equity is really at the heart and center of the ACA, and we really do have an unprecedented opportunity to close these long-standing pervasive gaps that we've seen over the years. And as Franklin D. Roosevelt said, the test of our progress is not whether we add more to the abundance of those who have much, it is whether we provide enough for those who have little.
Well, thank you, Nadia, and I'm sure we have about 10 minutes for questions. I know that was a lot of information. If you could just wait for the microphone to come around for your question, because we are being recorded, that would be great. Any questions?
If we switch to a single payer system, how much more money will we save and how much more equity will we have in our medical care system? Anybody trying to quantify or guess what that would be?
You know, I haven't quantified it. I don't know, Camille, if you've been looking into the cost, what it would save us. But again, I think it comes back to, one, I think that competes with our traditions and our values as a nation, so I don't think that's going to happen. But I think it comes back to the idea of we do have a good working system. It's really a matter of distributing resources, and working to match the needs of communities. And so without even going as far as a single payer, we might be able to work within the system we have to really begin to tailor to the needs of different communities and what they
It just seemed like one of the major problems was trying to educate people how to work a very complicated system, and that would be a major improvement in getting equity care out there.
That's right. But again, I think it comes down to just what you pinpointed. Education is so key. So even if we have a requirement in place, the education that would go into it, tailoring and reaching out to communities. Hey, now we have a single payer system in place. This is what you're required to do. I mean, that education will still be important and key. So I'm not sure, as I mentioned, health insurance is necessary, but I'm not sure if it's sufficient. I think there are a whole host of other factors that really contribute to health equity. But health insurance is key. Yes.
So you showed a slide that showed that Hispanics and at least one other people group had greater life expectancy, had less heart disease, less cancer. So I'm just wondering if instead of giving them a crate to the health equity fruit tree, we need to be getting a stepladder from them to either the lifestyle tree or something, because they have one of the highest inequities, but they have some of the better outcomes, self-reported and quantifiable. So maybe we're looking at things a little askew sometimes.
I completely agree with you, and that's one of the things we're really striving to do is not just look at health equity from that negative lens of what the problems are, but really now understanding how can we learn from communities that are doing better, that are healthier, that are living longer lives. And that's something that we're really striving to do when we develop our National Health Equity Index is why are some communities and some populations doing better? What can we learn from them? You know, who are the ones struggling? How can we can bring them up to that level? That was a great point. Thank you.
I do have a question, Nadia. One last question. Yeah, you mentioned, I believe, affordability of the plans, and as well as access to physicians is one of the sort of things. And I'm wondering whether one of the reasons why you see some of the disparities has to do with differences in the age distribution of the different populations that we're looking at. And I'm wondering if you looked at, if you standardized those rates by age to see what impact that would be, and whether or not you've been looking at things like the disparities in the distribution of the types of plans. Like, are some groups purchasing bronze plans more than, say, gold and silver, for example?
Absolutely. That's an excellent point, and especially the age distribution one. We haven't explicitly, so when we've done some of our community-based surveying, we haven't. It's hard enough to target the racial ethnic populations you want to target and get a sufficient sample. So we didn't add age as another stratifying variable, but that is something that's playing out in the national literature. That the age distribution, for example, of the white Caucasian population is very different from non-white and in particular Hispanic Latino populations, and how that might also be playing some role. So I agree with you on that, and we haven't done as much quantitative, but there is national literature emerging on that. And then your second question was
Which
around...
was looking at the distribution of the kinds of plans that have been purchased and whether or not there are differences by group.
We haven't looked into that, actually, the plan-specific differences as closely.
Yeah.
That was a good question.
Okay, any more questions? Okay, well, thank you very much, Nadia, and let's give her a round of applause.